and published almost 150 articles and book chapters. He's served on several committees at HHS, NIH, and CDC. Please join me this morning in welcoming Dr. Komarov and the clinicians panel.
Thank you. The panelists today are some of the most experienced and thoughtful clinicians and clinician investigators studying this illness over the last 20, 30 years. It's a pleasure to be with you. We're going to go down in the order we're seated here, and everyone can either speak from where you are or from the podium. If you have notes on your PowerPoints, they won't project on this monitor here, but they will project on the monitor at the podium. So let me begin by introducing Dr. Cindy Bateman, the Bateman Horn Center in Salt Lake City, who opened the conference, reminding us all, despite the fact we've been bathing in molecules for the last day, that it's about the patients that we're convened here, and we're trying to understand the molecules. So Cindy, you're going to talk. We're each of us going to talk for 10 minutes, and I'm going to give the hook to people who have gone past their time.
So you got a speed read.
Yeah, exactly. Cindy's going to talk about orthostatic intolerance.
So I want to talk about orthostatic intolerance because as clinicians, we try to find the low-hanging fruit. You know, how can we do something right away to help people improve their situation? The orthostatic intolerance syndromes are diagnosable and treatable, and we have actually a lot of evidence and a big literature about how to deal with them. And most of all, improving orthostatic intolerance improves symptoms and function and gives the patient more control. It's important to remember that there are many causes of orthostatic intolerance, and instead of just, that's the first step is to try to understand what might be behind the orthostatic intolerance. But one of the most important things is prolonged bed rest can cause severe orthostatic intolerance. So although it's not that easy to just say, don't spend time in bed, it is an important consideration when coaching people about their activity. And this is illustrated by astronauts who go out to space, and it takes about 3 weeks in weightlessness to develop severe orthostatic intolerance without informing your autonomic nervous system with gravity. There are also many things that we need to remember as clinicians, that many drugs can cause orthostatic intolerance. Prostate drugs, there is a kind of birth control that has drospirenone in it, which can cause orthostatic intolerance, and certainly heart and lung disease, central nervous system problems as well, as what we might consider neurogenic. And in our field, there are many causes of chronic OI that might cause small fiber neuropathy. There are post-viral syndromes and autoimmune processes. Many things can contribute to orthostatic intolerance syndromes. I wanted to make the point with this slide that acute orthostatic intolerance presents very differently than chronic orthostatic intolerance. When patients have an orthostatic intolerance syndrome that's chronic, their body adapts and the symptoms can be very nonspecific, and often patients are not even aware that they have orthostatic intolerance. They present with nausea and chest symptoms and headaches, sleep problems, and rarely, in my experience, do our patients pass out unless it's very, very severe. So it's helpful to teach the patients about avoiding triggers of orthostatic intolerance, very common sense things, getting overheated, dehydrated, prolonged upright position, and muscle atrophy. So, if they need to keep their core body and their lower body muscles as strong as they can and be aware of medications. And also, it's my experience that patients, all their symptoms worsen when they're in post-exertional malaise. So people may have mild orthostatic intolerance until their illness is flaring, and then the orthostatic intolerance becomes more severe. So my basic interventions for orthostatic intolerance, the first is to increase volume. And you can do that with fluids and sodium. There are medications to do it. The one we use the most frequently is fluticasone. I will say a word about desmopressin. Desmopressin is a drug version of vasopressin, and it's very effective at raising volume and has pressor effects. But you have to monitor very, very carefully because patients can become hyponatremic, especially our patients who are pushing fluids. But I've had very good success with desmopressin in patients who know how to report to me, and they kind of have a standing blood draw. And we all know that IV saline can be helpful for patients, although it's limited by access. So the second major intervention is compression. And this can be done with compression socks, compression clothing, and they are effective. They're as effective as the compression gets. And then we use a drug, midodrine, that's a peripheral alpha agonist that causes constriction of the blood vessels in the arms and legs. This is actually, their own body is doing this. The reaction to orthostatic intolerance, the adrenergic response, causes vasoconstriction. But the way I see this is you can do it with the medications, and then there's less of that adrenergic overdrive that makes people feel anxious and have palpitations and sometimes have trouble sleeping. I use some beta blockade, but it really depends on the patient, and it depends on the results of their orthostatic intolerance testing. And if I do, I usually start with very low dose propranolol. And I use the orthostatic testing to guide treatment. So instead of just having one test, one tilt table test, we do the 10-minute lean test to assess treatment efficacy and to make sure that you're hitting the right targets with your medications. I also wanted to mention that as Dr. Syndrome did, I've been using pyridostigmine, and in patients with POTS and ME, this has been an interesting and very effective intervention. I want to show you that if I have time. It's important to improve, I alluded to this, the muscular pump. So there are a few mechanisms that help venous return, and one of them is just the muscle pump. And the heart is no longer pumping venous blood. That pressure is pretty much gone, and there's reduced cardiac output. So I work with patients to develop the strength in their muscles and to remember to use their lower leg muscles as a way of encouraging venous return. And then exercise with orthostatic intolerance should be adapted, so exercise can be more effective. And I'm saying exercise in terms of movement at all levels, but patients should exercise in the supine or semi-supine position, reclining position, or in water. And if they have access to water to exercise, that is easier on their joints and their low back. You're either upright in a pressure tank, or you're horizontal. That mitigates the orthostatic intolerance symptoms, and it can be a very effective way to. Patients can do more exercise in water than they can do on land upright. And I wanted to just show you quickly. This is the patient that I mentioned in my initial talk. This is her vital signs on no medications. And you can see supine 98/70, her pulse is 85. And as she stood up for the test, her heart rate on no interventions went up to 168. On midodrine, propranolol, fluids, and compression, her baseline heart rate was 52 and went up to 109. And her blood pressure, supine 130, still dropped. She still had a 40-point drop in her blood pressure and a 57 beats per minute rise in her heart rate, but you can see that her heart rate is much more controlled, and this is a better state for her. But I want you to look at her on pyridostigmine. We added 30 milligrams of pyridostigmine 3 times a day. The first number, and these are standing blood pressures and heart rate. The first is before taking any medicines in the morning, and you can see she still has severe POTS in the morning with a low blood pressure and a high heart rate. This is after her first dose of propranolol and pyridostigmine, and the last number is after all 3 doses of propranolol and pyridostigmine. It's in this case, and this is the best case I've seen, I have to say, I'm presenting the anomaly, but after 3 doses of her medicines, she doesn't have POTS. her POTS is completely compensated. And this took her from mostly housebound to going out every day in the car with her mom. So light activity, she was able to go out. And the first thing that happened is she started getting post-exertional malaise. And I've had several patients with severe orthostatic intolerance say, oh man, I forgot what PEM was, because they were so limited by their orthostatic intolerance. So it doesn't eliminate everything about the disease, but you can take away one disabling part or mitigate it or improve it. And I think that's really important. I think my time is probably up, but I was just going to, I think I've got 40 seconds. So these are just some terms under the umbrella of orthostatic intolerance, which is really just a symptom presentation. Patients might get orthostatic hypotension. They may develop a rapid heart rate response, neurally mediated hypotension, and some of the synonyms are when there's a delayed syncope or orthostatic event. And then the term neurogenic orthostatic hypotension has been resurrected lately because of a drug on the market. And this really just implies that the cause of the orthostatic hypotension is a neurogenic cause. And for those of you who might have to do diagnostic coding, it's interesting because there really is no code, no billing code for POTS or NMH or NOH. The old codes for dysautonomias are there.